Good afternoon and welcome to our Neuroscience lecture series. I am Dr. Galat Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Ivan Vander. His presentation is titled Minimally Invasive Cranial Neurosurgery Approaches. Dr. Ivan Vander specializes in neurosurgery and is the director of endoscopic skull-based surgery and co-director of the Pituitary Tumor program at Baptist Health Miami Neuroscience Institute. Dr. Vander specializes in cranial neurosurgery with a subspecialty focused on brain tumors. He treats both benign and malignant tumors, including skull-based tumors, meningiomas, pituitary tumors, craniopharyngiomas, pituitary brain tumors, gliomas, and glioblastomas, and secondary brain tumors, as well as metastases. Dr. Vander earned his bachelor's degree in arts in neurobiology and behavior, magna cum laude in Cornell University in New York. He completed his medical degree at Weill Cornell Medical College in New York City and received the prestigious award titled Hodges Medical Institute Medical Research Fellowship. During his 7 years of training at New York Presbyterian, Dr. Cornell distinguished himself among his peers by being the lead in the Neuroscience Research Fellowship studies. Dr. Vander trained also including a neurosurgical oncology fellowship at MD Anderson Cancer Center, Neurosurgical Department, and Brain and Spine Center in Houston, Texas. To advance his studies in neurosurgery and neurosurgical oncology, Dr. Vander conducts extensive clinical and translational research. He has received numerous awards for his research accomplishment, and his work has been widely published in peer-reviewed medical journals, including Proceedings of the National Academy of Sciences, Cancer Neurology and Neurosurgery, Journal of Neurosurgery, and Journal of Neuro-Oncology. Dr. Vander is a member of the Congress of Neurological Surgeons and American Association of Neurological Surgeons. He is the author of several articles and book chapters in his field. Thank you so very much, Dr. Vander, for accepting our invitation. We are so thrilled to have you on our team. The floor is yours.
Thank you so much for that kind introduction. I'm going to go ahead and share my screen here. Hopefully this works. Sorry, 1 second.
Perfect.
Can you see the slides?
Yes, we do. Thank you.
Okay, perfect. Well, I just want to start by thanking you, Dr. Hakim, and the Baptist Health International Group for the opportunity to speak to everyone here and for organizing this conference. As you mentioned, I am now the Director of Endoscopic Endonasal Skull-Based Surgery and co-director of the Pituitary Center here at Miami Neuroscience Institute. And I recently just got here within the last month, so I'm very new to Baptist, and I'm excited to be here and to be speaking to all of you. So I have no financial disclosures to make for this presentation. Since it's the first time that I'm speaking at this conference, I wanted to give a little bit of background on where I come from and sort of where my surgical philosophies have been developed. So, I originally grew up in the Northeast in New York City, and that's also where I completed my neurosurgical residency at Weill Cornell, New York Presbyterian Hospital, and Memorial Sloan Kettering. And it was really at Weill Cornell at New York Presbyterian where I was introduced to the leaders in the field of minimally invasive neurosurgery. In spine, Dr. Hartle at Cornell had led the field in minimally invasive tubular spine surgery. Dr. Swaydan in pediatrics had been a leader in endoscopic ventricular surgery for things like colloid cysts and novel surgical therapies such as convection-enhanced delivery. And Dr. Schwartz, who I spent 6 additional months with doing an enfolded fellowship after my chief year, was internationally recognized for his work in endoscopic endonasal and minimally invasive keyhole neurosurgery. And following my residency at New York Presbyterian, I went on to do a fellowship at MD Anderson where I focused on advanced training on brain mapping and awake craniotomies, but also had the opportunity to work with Sean Raza, who is also advancing the field of endoscopic endonasal skull-based surgery for malignancies, such as sinonasal cancers, anesthesioblastoma, and chordomas, chondrosarcomas. So it's really with that background that I came to Miami Neuroscience, and I want to give credit up front to that many of the concepts that I'm going to share with you are built on the work that I did with these mentors and with these leaders in the field. And it's with that background that I am coming to Miami Neuroscience Institute in Baptist Health, South Florida, to help bring these techniques and surgical experience and philosophies to South Florida and beyond. So just for some historical perspective here, minimally invasive cranial neurosurgery has been a focus over the last 2 decades of tailoring our approaches within neurosurgery. But when neurosurgery was initially being developed, it really required large openings and large approaches. Historically, neurosurgeons didn't really have the high-resolution preoperative imaging and 3-dimensional neuronavigation that we currently depend on to tailor our surgical approaches. There were also limitations in visualization and lighting to see into deep and narrow surgical corridors. So large craniotomies and retraction or sacrifice of normal structures was actually often necessary and employed to reach the pathology of interest. A sort of interesting and perfect illustration of this is that Walter Dandy, who's one of the fathers of neurosurgery and one of the early innovators in neuroendoscopy, in the 1920s and 30s first described a third ventriculostomy. And to do that approach, he actually did a large terional craniotomy and sacrificed one of the optic nerves to access the lamina terminalis for this procedure. Nowadays, that would be unheard of to do that, but that was one of the initial ways that this surgical approach was innovated. So over time, and improvements in our abilities to use the intraoperative microscope and preoperative imaging and navigation, we've seen the ability to tailor our craniotomies and sort of shrink our exposures so that we can minimize the effect on the patient. We've also seen over the recent years a significant increase in the understanding of quality of life outcomes as a core component of our surgical decision-making and surgical outcomes. And I think this is particularly true in the days where gamma knife radiosurgery and radiation are becoming increasingly effective. We need to have surgeries that are equally effective without causing significant damage to our patients and allow for more minimal recoveries. So, beyond just the operative microscope and imaging and preoperative imaging, it's really the evolution of the endoscope that has led to a huge revolution in the field of neurosurgery and minimally invasive cranial neurosurgery. The endoscope was actually initially pioneered in the field of urology, and Harold Hopkins and Karl Storz were probably the 2 most well-known innovators in the development of the endoscope, and their work really advanced the design of endoscopes to allow for visualization and illumination at the depth of the surgical field. So it's important to note that a microscope at the source of lighting has a wide field of light, which is funnel shaped into a focus at the field of the operating field. While an endoscope, actually, the light source is narrow and provides a reverse funnel shape of light, providing a much wider field of view. And that source of light can be brought into the depth of the field. And so I think this illustration here is nice because it shows, and when you're using a microscope for endonasal procedures, your view is really limited by your retractors and the light source accessing the depth of your cavity, whereas with an endoscope seen above, you can see a much wider field of view with much better lighting. And so that change and that innovation with the endoscope has really allowed for a wide increase in the ability to do minimally invasive surgery. And in addition to that, we've also seen the use of angled endoscopes allow for viewing around corners, which is something that you cannot do with an intraoperative microscope. So it's really these innovations that have led to a revolution in the field of minimally invasive cranial neurosurgery. So what exactly is minimally invasive surgery? So minimally invasive surgery is really tailoring your opening and surgical approach to minimize the size and impact of your incision and your surgical opening. And why is this important? It's important because by minimizing the size of the approach, you're minimizing the normal brain that's exposed, as well as minimizing the disruption to and retraction of normal structures through that approach. So theoretically, the aim and the goal of the minimally invasive approach is to minimize the disruption of normal structures and therefore decrease the rate of complications and allow for easier or quicker recovery for patients. Ultimately, however, these minimally invasive approaches really need to be as facile and as good at achieving outcomes and good surgical resections and extensive resection as the traditional open approaches. So due to the sometimes narrow surgical corridor that you can use in minimally invasive surgery, there can be steep learning curves to using minimally invasive approaches. And I always like this quote that Dr. Schwartz would have when we would be doing some of these surgeries, which was that minimally invasive surgery is easier on the patient, but harder on the surgeon. And so I think that's really representative of the fact that while these surgical approaches are potentially very helpful for the patient, they do have a steep learning curve, and case selection is really key to achieve good results in these types of minimally invasive surgeries. So I want to start by discussing a few minimally invasive corridors to illustrate how these approaches, or what these approaches can accomplish, and compare them to their traditional alternatives. But I do want to say up front that it's important to mention that while I'm advocating for these approaches, they're not the only way to achieve resection of these pathologies, and there are certainly important case selection criteria to utilize these approaches, and they're not perfect for every case. So while I want to talk about what they offer, I do want to note up front that they're not perfect for every case, and you really have to be thoughtful about how you utilize these minimally invasive approaches. So the first corridor I'll talk about today is the endoscopic endonasal approach. And really, this is probably the most widely utilized and versatile of the minimally invasive approaches I'll talk about in cranial neurosurgery. It was initially described many years ago for transsphenoidal and transcellular approaches, particularly for pituitary lesions. But over the years, the use of the endoscope and the visualization it provides really allowed for the expansion of the endonasal approach to reach other midline skull base and craniocervical pathologies. And you can see in this image, which I think nicely represents this, that if the vector of the approach of an endonasal or surgery really allows, with illumination at the depth of the field, for you to see all the way from the frontal sinus and the cribriform plate, the crista galli, all the way back through the sphenoid sinus to the sella, down to the clivus, and through the parapharyngeal space, all the way down to the odontoid. So really expanded approaches in the endoscopic endonasal approach can allow you to reach a very wide range of pathologies. And so this is just a list of some of the pathologies that we can reach through an endoscopic endonasal approach and expanded endonasal approaches, such as non-functional and functional pituitary adenomas, Rathke's cleft cysts, arachnoid cysts, transtuberculum and planum approaches to reach meningiomas and craniopharyngiomas, transclival approaches to reach tumors such as chordomas or chondrosarcomas. You can see the transclival approach here. Transodontoid approaches for indications such as basilar invagination, transpterygoid approaches for CSF leaks or encephaloceles or Meckel's cave pathologies, as well as chondrosarcomas, and then transcribiform approaches at the anterior skull base for esthesioneuroblastoma, sinonasal carcinomas, and olfactory groove meningiomas. So really, this minimally invasive approach is actually a viable option for a wide range of pathologies, not just for pituitary tumors. And it's really important to note that all of these endoscopic endonasal approaches really require a multidisciplinary team-based approach with neurosurgeons and ENTs working together. And here at Baptist Health, our neurosurgery team includes myself, Dr. Seoman, and Dr. Wicks, as well as the ENT colleagues, Dr. Kanan and Dr. Pernas, who work with us to do these surgeries. So I like these pictures from Dr. Roten, who really wrote the textbook on neurosurgical anatomy, because he always talked about how you have to have three-dimensional vision during surgical approaches. You have to know what to expect on the other side of your approach. And so I think that these two images sort of very well represent that, with the left showing with the bone intact in most of the locations, and then with the bone removed on the right. And you can see with this endoscopic approach, you have a really excellent view of the entire anterior skull base, including the planum. You can see here the internal carotid artery on either side of the sella turcica. You can see the clinoidal carotid artery, as well as the clival recess here, with the paraclival carotid artery traveling down. You can also see the optic canal here and the lateral optic carotid recess. And if you look on the image on the right, you can see that those optic nerves, which would be traveling in the optic canal. You can see that clinoidal carotid artery, as well as the ophthalmic takeoff from the carotid artery and traveling underneath the optic nerve. And you can see the pituitary tumor, or sorry, the pituitary gland here. And you can imagine how if you had a tumor, such as a tuberculum sella or a planum meningioma, why these tumors would be compressing the optic nerves and often displacing the optic chiasm due to growth and pushing up on the optic chiasm right above it. So while pituitary and sellar tumors are probably the most common bread and butter case for an endoscopic endonasal approach, I wanted to talk about some of the work that's been done and that we've done to investigate using these endoscopic endonasal minimally invasive surgery approaches for pathologies that are a little bit more controversial or advanced uses, such as for tuberculum and planum meningiomas and craniopharyngiomas. So the real main advantage of the endoscopic approach is that as opposed to a transcranial approach, which requires retraction of normal brain and places neurovascular structures in between you and the tumor, the endoscopic approach brings you right to the tumor and you interact with the tumor before you have to deal with the optic nerves or the vessels around these tumors. Sorry, here we go. And so the approach for tuberculum and planum meningiomas, as well as craniopharyngiomas, is relatively similar and includes an adequate bone opening with opening the top of the sella, the limbus sphenoidale, the tuberculum, and the planum, as needed for meningiomas. And then it's important to note that operative adjuncts such as Doppler ultrasound and neuronavigation are really important to identifying where the carotid arteries are and protecting the carotid artery during your exposure. Once you expose the bony opening, then you can identify the superior and anterior aspect of the tumor capsule and then proceed with internal debulking. And once you've completed internal debulking, you can then begin to work around the top of the tumor, dissecting using bimanual dissection vessels and the optic nerves, which may be involved around the tumor. And it's important to consider if you need to open the optic canals to visualize the optic nerves and potentially and keep in mind the ophthalmic artery runs underneath the optic nerves and the optic canal. And the advantage of this bimanual dissection and this visualization is that you can see the vessels traveling underneath the optic nerve and over the tumor, and that really allows you to dissect them off the tumor. Whereas in a transcranial approach, you're really working underneath the optic nerves and you can't visualize those vessels as easily because you are coming in from above. And so in addition to being able to visualize that, you can achieve good control of your optic nerves and protect those during your surgical resection. Once you complete the resection, you can actually see that in this surgical video, you have sort of this beautiful view of the third ventricle and foramen of Monro above. And then you need to importantly have good reconstruction of the skull base, where at Cornell, sorry.
Thanks for coming.
Sorry, where in reconstruction you can use what we did at Cornell, which is a gasket seal closure with a solid med-pore closure and an inlay of allograft or fascia lata. And then this can be followed by hydroset and a nasoseptal flap to decrease the rate of CSF leaks, which is probably the most common complication of these endoscopic endonasal surgeries. So to determine whether there's really any advantage to approaching these tumors, such as tuberculum and planum meningiomas, through an endoscopic route versus a traditional transcranial approach, we reviewed all of the tuberculum sella and planum meningiomas that were resected at Cornell during a 10-year time period, and we identified 35 tumors that were reviewed by an independent panel of skull base experts and felt to be equally resectable by an endoscopic or a transcranial approach. That way, we were comparing apples to apples and making sure that the tumors were equally resectable by both approaches. We then went and did volumetric analysis to evaluate the extent of tumor resection, as well as look at the change in postoperative flare and DWI signal as correlates of traumatic injury to the surrounding normal brain around these tumors. And what we found was that gross total resection rates or near total resection rates were excellent in both approaches. The endoscopic endonasal approach had a 94% gross total resection or near total resection rate, and the transcranial approach had an 86%, and this was not significantly different. And more interestingly, what we found was that if you looked at the volume of postoperative flare or vasogenic edema within the brain, or at the volume of DWI restriction, which is representative of cytotoxic edema, we saw that there was a significant increase in the volume of flare or DWI signal in a transcranial approach compared to an endoscopic endonasal approach, suggesting that there was significantly more trauma to the surrounding normal brain with these traditional transcranial approaches. In addition to that, we also evaluated the visual outcomes in these patients because, as I mentioned before, these tuberculum and planum meningiomas often compress the optic chiasm and can present with visual deficits. And what we found was that patients who underwent an endoscopic endonasal approach had a higher rate of having improved or stable vision compared to transcranial approach patients who were more likely to have worsened vision after surgery. In terms of complication rates, we saw that patients who underwent a transcranial approach actually had a significantly higher rate of postoperative seizures, again, likely because of the damage to normal brain that can occur through a transcranial approach. And endoscopic endonasal patients did have a significantly higher rate of CSF leak, which is, as I mentioned, one of the most common complications of an endoscopic approach. However, the CSF leak rate has been decreasing over time with improvements in our surgical closures. So we weren't really the only group with interest in this topic. It was actually Dr. McDermott, who's the CEO here of Miami Neuroscience Institute, while he was at UCSF, who organized a collaboration with an international group, a study group that looked at a multi-institutional study of over 900 patients to define and refine preoperative risk scores for tuberculum and planum meningiomas and compare outcomes between endoscopic and transcranial approaches. And while I'm not going to go into all of the details of the findings of this study, one of the important findings was that for patients who had preoperative visual deficits, already preoperatively had some compression of the optic chiasm and were coming in with visual deficits, what they found was that the endoscopic endonasal approach, as we had found in our study, did lead to better visual postoperative outcomes compared to the transcranial approach, which was more likely to result in stable vision, while the endoscopic endonasal approach was more likely to result in improvement in vision postoperatively. In addition to that, they also did identify that for patients that underwent an endoscopic endonasal approach and achieved a gross total resection, they were less likely to have a recurrence because endoscopic endonasal resections involve resection of the bone and the involved dura in these meningiomas because of the vector of approach, which you cannot achieve through a transcranial approach. So this paper was really important in sort of defining what the advantages of an endoscopic endonasal approach are, but also of defining patients who may not be appropriate for an endoscopic endonasal approach. Patients with larger tumors that encase the carotid arteries or the anterior cerebral arteries, or tumors that invade into the optic canals may be less appropriate for endoscopic endonasal approach and may benefit from the more traditional transcranial approaches. So craniopharyngiomas, as I mentioned, are approached in a similar way, and we also wanted to compare outcomes for endoscopic endonasal versus transcranial approaches for these craniopharyngioma patients. And so similarly, we had a panel of skull base experts review all of the cases that had been completed at Cornell. And we found that 26 cases were equally well approached through an endoscopic endonasal or a transcranial approach. And in this case, actually, endoscopic endonasal approaches achieved a significantly higher rate of gross total resection compared to transcranial approaches. 90% of patients who underwent an endoscopic endonasal approach for craniopharyngiomas achieved gross total resection versus only 40% in the transcranial group. We similarly found that there was a significantly larger volume of flare vasogenic edema after transcranial approaches compared to endoscopic endonasal approaches. And due to the lower rates of gross total resection, the transcranial patients were more likely to undergo adjuvant radiation or have postoperative recurrence. In addition, we looked at the visual outcomes and found again that endoscopic endonasal patients were more likely to have visual improvement postoperatively compared to transcranial approach patients. So the last pathology I'll talk about from an endoscopic endonasal approach standpoint is the use for chordomas. And chordomas are a malignant brain tumor which can arise from remnants of the notochord in the axial skeleton, and about a third of these chordomas occur within the clivus. And as they grow, they can begin to compress the brainstem and invade around the structures around it. So it was actually Sean Raza's group at MD Anderson who did a comparison of the endoscopic approach versus traditional open approaches for resection of clival clival chordomas. And what they found was that patients who had upper or middle clival lesions were more likely to achieve gross total resection for upper clival lesions if they underwent an endoscopic endonasal approach compared to an open approach. And they also had significantly longer progression-free survival in patients in upper or middle clival lesions. In addition to that, they found that there were shorter times to initiation of radiation for patients that underwent an endoscopic endonasal approach compared to an open craniotomy, given that these patients had quicker recovery after surgery. So I think this is sort of a nice video demonstration of endoscopic approach for a clival chordoma. And this patient was 62, had presented with double vision, dysphagia, and gait instability, and was found on imaging to have a large 4-centimeter clival lesion, classically T2 flare hyperintense, causing significant brainstem compression, explaining her presenting symptoms. And so this patient underwent a endoscopic endonasal approach for resection of this tumor at Cornell while I was there with Dr. Schwartz. And so you can see in this case, we're exposing the sella, the clival recess, drilling the clival recess and exposing the carotid arteries on either side of the sella here, as well as exposing the paraclival carotid arteries here, doing a posterior clinoidectomy from endoscopic endonasal approach, and then debulking the tumor significantly. And you can see here with using angled endoscopes and angled instruments, we can actually reach behind the paraclival carotids to reach tumor behind the carotid arteries. And you can see the dura here is well decompressed, and we actually used endoscopic ultrasound to confirm that we had resected the tumor. In this case, the tumor had not invaded through the dura, and so there was only a minimal CSF leak. And you can see here the basilar artery along the brainstem pulsating nicely. And then again, that nasoseptal flap closure. Pathology was confirmed to be chordoma, and you can see the excellent resection here that can be achieved through this endoscopic approach. So a pathology that I want to talk about next is similarly a midline skull-based lesion of olfactory groove meningiomas. And these lesions occur along the cribriform plate and in the anterior skull base, and so theoretically are accessible through an endoscopic endonasal approach. But one thing that's important to note about an endoscopic endonasal approach for these olfactory groove meningiomas is that in doing an endoscopic endonasal resection, you have to take the olfactory epithelium and cribriform plate, which results in anosmia or loss of sense of smell and taste in 100% of patients if you do this endoscopically. So since many of these patients do still have intact olfaction preoperatively, we would argue that endoscopic approach with resulting in anosmia in 100% of cases would not actually be an ideal quality of life outcome. So in these cases, we actually would recommend undergoing a different minimally invasive approach, which is a keyhole supraorbital approach with endoscopic assistance. And so that entails incision in the eyebrow, which you can see here, lateral to the supraorbital nerve, and basically a frontal craniotomy for resection of these tumors. And using an endoscope for assistance, you can visualize to the anterior cribriform plate. And so the supraorbital craniotomy was actually first introduced by Axel Pernesky. And this figure from his paper back in 2005 shows how over time they were able to shrink the frontotemporal craniotomy and the terional craniotomy to basically just this frontal craniotomy through an incision in the eyebrow to allow for access to the anterior skull base. And the advantage of this is that you don't have to disrupt the temporalis muscle in doing this approach. You have minimal disruption of the temporalis, which can allow for significantly less postoperative pain and discomfort for the patient. And so this figure, I think, nicely represents what you can access through these keyhole approaches. So from a supraorbital craniotomy, you can see this representation in light blue and in red, labeled 1 and 4. And this is what you can reach through a supraorbital craniotomy. And then if you add an endoscope, an angled endoscope, you can actually add a view anteriorly to the cribriform plate and see all the way to the crista galli using an endoscope at the end of the surgery. And I included this picture from an intraoperative case where we used an angled endoscope, and you can clearly see here all the way to the crista galli, and you can see the intact olfactory nerve laying here after resection of an olfactory groove meningioma, laying within the cribriform plate. So similar to the other articles that I mentioned, we wanted to assess whether there were any significant advantages to this more minimally invasive supraorbital approach for olfactory groove meningiomas compared to the traditional transcranial approaches, which require much larger openings, as I mentioned, through a frontotemporal or a orbitozygomatic craniotomy or even a bicoronal craniotomy. And so we reviewed all the cases that had been completed at Cornell and compared those cases, again, selecting only cases that could be equally approached through either a supraorbital or a traditional transcranial approach. So we excluded patients who had large aerated frontal sinuses because that would limit the ability to do a supraorbital craniotomy and have appropriate reconstruction without risk of CSF leak. So these patients were excluded. And we also excluded patients who had olfactory groove meningiomas that grew up the back wall of the inner table of the frontal sinus, where you cannot reach even with endoscopic assistance through a supraorbital craniotomy. And we also excluded patients who had scaphoid sphenoid bones, given that the tumor located behind the scaphoid bone would actually be hidden from view for a supraorbital approach and make resection much more difficult. And as I mentioned at the beginning of the talk, this is sort of the important key case selection criteria that you have to use when you're considering a minimally invasive approach. And so we compared the outcomes of the patients that had undergone surgery for the olfactory groove meningiomas at our institution. And what we found was the extent of resection for both traditional transcranial and supraorbital approaches were similarly excellent, with 98% extent of resection or 99% in both groups, which was not significantly different. The number of patients who had intact olfaction postoperatively was also not significantly different between the two groups. Both groups had about 40% of patients maintain olfaction postoperatively. And the significant difference that we did find was that if you compared the length of stay between a supraorbital craniotomy or a traditional transcranial approach, we found a statistically significant decrease in the length of stay for supraorbital craniotomies, averaging about 4 days after surgery compared to, on average, 9-day stay after traditional transcranial approaches for these patients. And looking at the complication rate, there was really no significant difference between overall complications between supraorbital approaches and traditional transcranial approaches. But one thing that's important to note is that we did find that the supraorbital approach was more frequently used in smaller olfactory groove meningiomas. So we did sort of stratify the large tumors and small tumors and compare our results within large and small tumor subpopulations, and similarly found the same results, that extent of resection, change in flare postoperatively was not significantly different between approaches, but the length of stay was shorter for supraorbital craniotomy patients for small tumors as well as large tumors compared to the traditional transcranial approaches. And this is likely, again, because of the less disruption of normal tissue, less retraction of normal brain, and not having to disrupt the the temporalis muscle, which results in less postoperative pain and allows for a quicker recovery for the patients. So the last endoscopic or minimally invasive corridor I wanted to mention is one of the more novel minimally invasive approaches that has been recently developing, and that's the endoscopic transorbital keyhole approach. And it's really been within the last 5 to 10 years that Doo-Sik Kang in South Korea and Chris Moe at the University of Washington, as well as Ted Schwartz at Cornell, have pioneered these approaches for transorbital neuroendoscopic surgery. Traditionally, the transorbital approaches were really used for just orbital lesions, but in the last 5 to 10 years, we've seen these approaches increasingly used to reach lesions in the skull base and intracranial lesions as well. So for an endoscopic transorbital approach, you're making an incision within the superior eyelid crease, so below the eyebrow for the supraorbital craniotomy, and then you're releasing the periorbita and orbital contents from the bony attachments to mobilize those medially, and then accessing the middle cranial fossa by drilling the greater sphenoid wing located between the superior orbital fissure and the inferior orbital fissure. And by drilling and removing that bone, you can then access what's shown here in purple, which is the middle cranial fossa through the endoscopic transorbital approach. And so this is a heat map representation of meningiomas that were resected at our institution, either through an endonasal approach or a supraorbital approach, and then more recently through an endoscopic transorbital approach. And I think this nicely demonstrates how the transorbital approach is sort of expanding our minimally invasive toolkit to allow us to reach beyond just the anterior cranial fossa with endonasal approaches to reach also lesions within the middle cranial fossa. And so since this approach is more relatively recent, it's only been evaluated in a smaller subset of patients. But one of the sort of the cases that I think are well treated or appropriate for these endoscopic lateral transorbital cases, one of which I think is sphenoorbital meningiomas, and some select middle fossa meningiomas, depending on the extent of the involvement of the middle fossa. But one of the advantages of this endoscopic transorbital approach is that in many of these sphenoorbital meningiomas, you have hyperostosis of the bone, and this approach through the transorbital craniotomy allows you to actually directly drill this bone, much like the endonasal approach allows you to drill the bone and dura involved in tuberculum sella or planum meningiomas. In the transorbital approach, you can drill the involved bone and reach the dura for sphenoorbital meningiomas or select middle fossa meningiomas through a lateral transorbital approach. And one of the other nice indications for a lateral transorbital approach is lesions within the lateral cavernous sinus, as well as Meckel's cave, because again, it's directly within that line of approach. As you drill that greater sphenoid wing, you gain access to the cavernous sinus, and depending on where the lesion is within the cavernous sinus, if it's medial to the internal carotid artery, it's probably better approached through an endoscopic endonasal pathway. But if it's lateral to the internal carotid artery, a transorbital approach may be appropriate for those cases. And so we've published a series of cases involving cavernous sinus tumors and Meckel's cave lesions that have been approached through a lateral transorbital endoscopic approach. And this is sort of a nice case example of that. This is a 24-year-old patient who presented with trigeminal pain in the V1 distribution, as well as a sixth nerve palsy, and was found to have enhancing tumor within his cavernous sinus on the right side. And, this is a 24-year-old, so we needed to have pathologic diagnosis to understand exactly what kind of tumor this was. And as opposed to doing a large pterional craniotomy or a Dolenc approach to reach the cavernous sinus to sample the tumor, or just radiating this without any pathologic diagnosis, we decided to use an endoscopic transorbital approach to reach this tumor. And similarly to a Dolenc approach, you do expose the cavernous sinus and the nerves that run in the lateral wall of the cavernous sinus. And you can similarly open through the same triangles that have been described for cavernous sinus approaches through a lateral transorbital approach. It's just a different angle of viewing. And so for this case, we did a preoperative embolization because it was seen to be highly vascular on preoperative imaging. And then we did the lateral transorbital approach, and you can see a retractor being used to retract the orbital contents medially, and then the drill being used to drill the greater sphenoid wing. And you can see here release of the sagittal crest, which is basically a bony structure sitting in between the frontal and temporal dura. And as we retract the orbital contents medially, you can see here cutting the meningo-orbital band from the transorbital approach, which we're used to seeing for an open craniotomy. And this allows us to extend the retraction more medially and allow us to separate the frontal and the temporal dura as we resect this lesser sphenoid wing. And you can see here, again, sort of retracting the dura off of the cavernous sinus and exposing the lesion within the cavernous sinus wall. And one of the nice things I want to show here is comparing the view that you have within a microscope for this surgery. You can again see how limited that view is with the light. Again, with a funnel shape, you can't achieve as good visualization at the depth of the cavity. So you're working with much worse visualization with a microscope as compared to, if you look with an endoscope, you can see here how much nicer the visualization, the view is using an endoscope, and again, allowing for bimanual dissection with much better visualization of the surrounding structures, and a much arguably safer surgery with an endoscope compared to a microscope for visualization. And so in the end, the pathology of this tumor turned out to be a solitary fibrous tumor. And really what's important to note is that in these endoscopic approaches to the cavernous sinus, the goal of surgery is really important to consider as well, because gross total resection in cavernous sinus lesions puts you at higher risk for having cranial neuropathies postoperatively. And so for cases like this, our goal was not to achieve a gross total resection, but to obtain a pathologic diagnosis and create a smaller lesion size for stereotactic radiosurgery to ultimately treat this tumor. And so it's important going into these cases, one, identifying where the carotid artery is relative to your lesion, and then two, knowing what your goal of surgery is and what your end goal is. And so just to conclude, I want to sort of summarize what I've talked about today, which is that minimally invasive approaches are really growing and allow us to reach a wide variety of indications and regions of the skull base. And that's just increasing over time. And really that case selection is vital and key, and not all cases are appropriate for minimally invasive surgery. But for appropriately selected cases, surgical outcomes such as extent of resection are on par with traditional approaches to these lesions and can offer some key advantages, which I hope I've described. So the last thing I want to mention is just that the continued development of the evidence base in this field of minimally invasive or minimal access neurosurgery is really important. And our hope is to continue evolving this field to minimize the amount of pain that our patients have to go through post-operatively to achieve excellent surgical outcomes while also minimizing the impact on our patients. So I just want to acknowledge Dr. McDermott here, who is the CEO of Miami Neuroscience Institute and who helped recruit me here, as well as our whole Miami Neuroscience Institute and Miami Cancer Institute team, and Dr. Schwartz, who is a big mentor of mine and obviously who I've done a lot of work with on this topic. So that's it. I'll stop sharing my screen and we can take any questions.
Thank you so much, Dr. Van Der. It is remarkable how you guys have changed the paradigm in treating neurosurgical conditions through all these incredible new approaches and techniques. And Dr. Schwartz was right on point to have trained you and selected you as well. And for him to say that it's easy on patients, but it's hard on the surgeon, that is not only wise, but we could actually see by being fascinated with what you presented here, how difficult and complex and hard could be on a neurosurgeon to approach all these tumors. Obviously, we don't want to dismiss the fact that the traditional ways of approaching and removing these tumors in other parts of the world still perhaps the leading way of actually doing it. But with the advent of new technology, the advent of new evidence, and the research that it's being backed by the number of cases that you guys are doing, it's perhaps where it's going to start changing around the globe, the approaches to this. I must mention something that you did address and say, which has to do with one of the concerns typically, which is the CSF leak. And you did mention it's still high, but we're getting to a point in which we're seeing some decrease. What motivates you to actually say that? I mean, are you working on new techniques in order for you to seal that area that you have exposed?
Yeah, so I mean, there's constant innovation really within the field of minimally invasive surgery because of, as we push the field forward, we find new issues and new complications that we have to manage and how to deal with those. And so CSF leak has, since the beginning of endoscopic endonasal surgery, really been one of the limiting factors in the uptake of endoscopic endonasal surgery. Initially, CSF leak rates were as high as 30%. And it's really been innovation over the last decade or so, and what Dr. Schwartz's innovation with the gasket scale closure that has decreased that rate closer to about 10% or less, depending on the pathology that you're dealing with.
Mm-hmm.
And the use of lumbar drains has helped to decrease that. And so one of the things that we started to do while I was at Cornell with Dr. Schwartz was using the use of Hydroset to help with this closure. And that's been something that's been sort of explored by him as well as some other surgeons in the field to aid in the closure, to sort of reconstruct a real bony closure around our opening so that the likelihood of CSF leaking out is lower. And there has been some early evidence that this may be beneficial and lower the rate of CSF leak, but this is something that we're constantly trying to innovate on and improve over time.
Mm-hmm.
And I do want to just follow up on one of the things that you mentioned, which is that, yes, I think that it is important to realize that these approaches, while they are potentially beneficial, are not, as I said, the only approach to do these tumors, and not always appropriate in certain settings, because really it's the visualization that's key. Mm-hmm. And, in doing these surgeries, you really have to have the appropriate team and team-based approaches. And, craniotomies are equally, as I've mentioned in most of these papers, have very good outcomes. And we've, trained in these approaches for years. So I would argue, it's really important to, as you uptake these new approaches, to make sure that your outcomes are on par with what you're achieving through an open approach.
Yeah, and the other remarkable thing is the length of stay that the patient is actually, um, getting to use in a hospital versus the extensive and tedious recovery of a patient that traditionally gets approaches of that nature. So that is obviously one of the biggest benefits, and of course the side effects or the comorbidities that might come after that sometimes a neurosurgeon cannot help because it is the nature of the actual beast that you're dealing with and the
Right.
extent of the surgery. And the other important thing that we need to mention again, because you wisely said it, and it's that you do tend to sometimes contribute in reducing the size of the tumor so radio oncology can come on and just do radiosurgery on the patient. So it is a combination of approaches through the interdisciplinary team to actually tackle a particular condition, that this is not
Yeah,
solely on the neurosurgeon, that you have a battalion of individuals that contribute
absolutely.
to this.
Yeah, I think that's an excellent point, is that knowing your goal of surgery and what you're trying to achieve is vital going into the case. And one, in achieving safety, and two, in achieving the goal for the patient. Again, depending on what their quality of life outcomes or what their goals are, and what you need to achieve is important to know going in.
The other wow factor for me was when you mentioned that through the endoscopic keyhole, you can actually approach the base of the skull, which is, I mean, mind-boggling just to think of a neurosurgeon trying to approach that particular very delicate piece of anatomy to remove a tumor. So this is absolutely phenomenal, doctor. If I was to ask you, are you excited at any for any new technologies that is coming your way, or new research or new studies? What would that be? What is the first thing that comes to your mind?
Yeah, I mean, I think as we've talked about, sort of just continuing to grow the field of minimally invasive surgery, I think is vital. In the last, it's easy to continue doing what we've always done. And I think, it's in our nature, once we know how to do something, to continue doing it that way.
Right.
But I think one of the things that I really took away from working with Dr. Schwartz is to never accept what the way you do it now as the only way to do it. And so I think continuing to advance our use of endoscopes and our use of improvements in visualization and illumination. Things like exoscopes are also becoming more popular now, and potentially allowing us to do things that we didn't used to be able to do with a microscope. And so I think it's really about making sure that we continue to innovate, and
Mhm.
just to continue trying to improve our field and improve the impact on our patients is
Yeah.
what's really important.
And another incredibly important pearl that you just left us with was the case selection, the importance of case selection, that not every single type of adenoma in the pituitary can actually serve the purpose for, this type of approaches can serve the purpose of removal or any other condition for that matter.
Right.
And doctor, a quick question. Can you use any of the minimal approach type of approaches for schwannomas, acoustic schwannomas or neuromas?
Yeah, it's a great question. So, it hasn't been one of the more common uses of endoscopes, but there are innovators who are using endoscopes in the posterior fossa for things like microvascular decompressions, for smaller approaches to that. And absolutely, I think it is a field that may continue to develop over time as use of endoscopes or exoscopes for vestibular schwannomas, because again, it allows you for better visualization at depth, which is something that you do need for vestibular schwannomas. And through that, you could shrink your approach in these cases as well, but it's not something that's been as clearly worked on.
Wonderful. Well, one last comment, and it's from Dr. Ramirez from San Salvador. She says, thank you for the valuable information. I'm very grateful for your invitation. I agree with everything that you said, and we're very, very fortunate to have you as well, Doctor. So thank you so very much. I'm going to let you go. I know that you're a busy man, but
Thank
we
you
are
for having me.
so, so thrilled to have you in our team and learn from you. and hopefully participate in some of the neurosurgical conferences abroad. So we look
Yes,
forward to more. And
absolutely.
on behalf of our entire international team, thank you once again, and to all of you for participating and for your attendance. If you have any questions for Dr. Vandel, please send them to BHIWebinars at baptisthealth.net. Again, that is BHIWebinars at baptisthealth.net. We'll make sure to get it to him for him to respond, and we will send it immediately to you. We look forward to seeing you all in our next neurosurgical lecture series, and we will be sending an invitation shortly. Thank you once again, and have a great afternoon. Thank you, Dr.
Thank
Vandel.
you so much.
Have a good week.
Have a
Bye.
great day.